know that my ancestors have flourished and with respect to some of the elements in which the Mi'kma'ki people did not. And so just to acknowledge that we are certainly moving forward with reconciliation, and that just to truly acknowledge that we are in the land of Mi'kma'ki and that we all are treaty people. So today, I'd also like to welcome you all to our Center for Transformative Nursing and Health Research, our annual or our monthly webinar, and am just so privileged today to have two speakers talk with us. And today, is it? I have to ask, is it Arezoo? Mobab? How do
My
you
name
say
is
your last?
Arezoo Mojbafan.
Arezoo
Mojbafan.
Mojbafan.
Yeah, that's correct.
Well, I thank you so much for being here today. And you are a PhD student, correct, in the PhD of Health program. And what year are you?
I'm a second year PhD student.
Excellent. And who are you working with?
Dr. Elaine Moody and Dr. Lori Vicks.
Oh, well, that's fantastic. That's a powerhouse supervision team. Well, we're so excited for you today. You're going to talk about health inequity and accessing primary health care among older adults in Canada. Is that right?
Yes, that's correct.
Well, so without further ado, thank you so much for being here today. I see your supervisors and others, and we're really looking forward to hearing your talk.
Thank you. Well, let's share my screen. Can you see my screen?
Yes.
Yes.
Hello, everyone, and thank you so much again for having me today. My name is Arezoo, and I'm here to talk about my PhD proposal, which is about health inequity in accessing primary healthcare services among older adults in Canada. Now I'm going to talk about a little bit about the background of my topic. You know that actually the accessibility and universality are two important criteria in Canada Health Act, which provide a foundation for equitable equitable access to healthcare services for all Canadians, regardless of their age, immigration status, or socioeconomic status. But despite this fact, we can see that actually, the Canada still trails behind so many high-income countries in terms of the providing equitable healthcare system. And these differences in the quantity and the quality of the services have been perceived due to their socioeconomic status, gender, race, ethnicity, and geography. Well, as I said, despite the fact that actually the Canada provide free provision of healthcare services for all the Canadian, but there isn't any universal coverage for prescription drugs, dental care services, eye care services, and outpatient rehabilitation. And it seems that this inequality in healthcare system is in favor of the people with a higher socioeconomic status. And we can say that that the people with, especially the low income older adults, they do not have access to the family physicians or a specialist. Well, health inequity is defined as a differences in health status or in distribution of the health resources between different population groups arising from the social conditions in which people are born, grew, live, work, and age. And they are unfair and unjust and could be reduced by the right mix of government policies. So based on this definition, you can see that actually health inequity is completely different from the health inequality. Health inequality just refers to the uneven distribution of the health and health resources, and there isn't any moral assessment to see these actual differences are unfair or unjust. So, in other words, we can say that actually health inequity is the ethical dimension of the health inequality. Well, why we should focus on a primary healthcare? You know that actually primary healthcare is a broad concept, and it's not only include health but also other services that have an impact actually on health, such as income, housing, environment, and education. And the primary care, which refers to the first point of the contact with the actually healthcare system and having an appointment with the family physicians, it's the one element within the primary care, primary healthcare. And so the primary healthcare, apart from that, actually treating illness and injuries, it also includes health promotion services, mental health services, and disease preventions. Well, despite the fact that actually there have been a substantial improvement, in healthcare system and mortality rate, morbidity rate, but we can see that actually health inequality have been widened among actually both within and between countries. And the WHO actually has stated that we should take primary healthcare as a great strategy because it's implemented interventions in order to address a broad social determinants of health, such as economic and social conditions like structure of the healthcare system, which is actually shaped by money, resources, and power, and have a great impact on individual and group differences in health status. Well, primary healthcare values and principles, which include health equity, people-centered care, and central role for community in health action, provide a better response actually to expectation and challenges of the modern society. And based on these principles, we can see that actually primary healthcare, searches for strategies in order to achieve more equitable and comprehensive healthcare system and also provide a better population health. The Commission on the Social Determinants of Health also has stated that the healthcare system, with the universal coverage and with a focus on the primary healthcare, they can provide and generate actually locally appropriate interventions in order to address the social causes of inequality. Besides, based on the evidence, we can see that actually primary healthcare has a great impact on improvement of the health outcomes and also increasing life expectancy and reducing mortality rate. Well, apart from that, actually, older adults in Canada, we consider older immigrants who account for a large percentage of the older population in Canada, around 30%. They face more barriers. That these barriers actually affect their ability to access to these services and also the quality of the services they received. You know that the primary care physician play important role in order to help them how to manage the chronic diseases, which is quite prevalent among these groups of population. We can see that actually they face so many barriers such as cultural differences, language discrimination, traditional health beliefs. There's a lack of awareness about the services that are available for them, lack of transportations, and this actually poor access to these services go hand in hand with the insufficient financial, human, and information resources, and also an adequate geographical coverage of the services, which result in a resultant experience for all the immigrants. Because of the lack of proficiency in a host country's official language, they maybe use their friends or families or maybe hire someone as an interpreter in order to help them to access to these services and use them. But again, just because of the privacy reasons or because of the accuracy of this interpretation, especially during the physical examination, they are reluctant to use these actually interpreters. And another study on a recent old immigrants in Canada, we can see that they're relying on the hospital emergency rooms and walk-in clinics rather than the family physicians, because most of the time these actually family physicians in their neighborhood do not accept new patients, and because of the limited mobility for these groups, and because of they do not have a timely access to the family physician and services, they prefer to use these services rather than the family physician. About the health promotion and cancer screening among the old immigrants. Again, some of the barriers that the old immigrants face during using these services is that, well, health illiteracy, language discrimination, cultural differences, traditional health beliefs, that all of them prevent them in order to from seeking cancer information and participating in cancer screening. And it also shows that based on evidence that most of these old immigrants, they do not know about the nature of the actually screening or the procedures or where these services are located. And in some of them, especially South Asian immigrant women, they have a strong preference for family for a female physician, and that's why they do not actually use these services a lot compared to the Canadian older people. Well, a mental health services also again are underutilized with this type of people, just because of the few mental health worker, limited awareness about the mental disorder, and rely on actually ethnic specific agency that do not help them to address those problems. And sometimes because their friends or families do not acknowledge that they have a mental issues because of the cultural stigma associated with it, and health literacy, language barriers, and health beliefs. So, in order to say that some of the intersecting factors that shape access to the services among the older immigrants, we can say one of them is the health literacy. As I said, most of the old immigrants, they do not know about the services that are available for them or about the nature of those services or the procedures. And sometimes some of them they maybe find, actually, a Canadian healthcare system is quite confusing for navigate. Some of them think that the services that are available for them they are actually incompatible with the traditions and health beliefs, and or these services are not provided in the desired language. Another barrier is that actually geographical barriers and special access. You know that the frequency of the traveling well decreases with age, but traveling to another neighborhood or another city within Canada is unavoidable for especially for old immigrants because clustering healthcare services and physician services in a high density areas, high density urban areas provide actually cause so many problems for all the immigrants in order to access to these services. Another one, or we should mention that the most important one is that the culture and language barriers. As I said earlier, most of the actually all the immigrants do not have any. There is a lack of proficiency in a host country's official language, and in Canada, all the immigrants they do not have actually enough opportunity to become proficient in English, and they are reluctant to use interpreters in order to help them to use the services. But some study mentioned that actually increasing the length of the residence in Canada has been associated with increasing health literacy and acculturation. But we can see that among the especially South Asian immigrants who have resided in Canada for 20 years, they do not actually they still do not use actually screening services just because of the cultural barriers and language barriers. And these cultural differences between the providers and the patients has actually a negative impact on their communication just because of they may misinterpret the symptoms, patient symptoms, and or they maybe find it difficult to transfer this information, medical information, to those people. Or sometimes some of these old immigrants they may be found that their traditional health beliefs are not honored actually in Western healthcare system. And the last but not least barrier is that the socioeconomic and structural barriers. The structural barriers can refer to the, for example, shortage of the family physicians or other providers who provide who can speak actually non-official language. And socioeconomic barriers, we can say that actually in Canada, as I said, despite free provision of the services, this actually province insurance just cover necessary medical medical necessary services and physician services. And there isn't any universal coverage for prescription drugs, eye care services, dental care services. So they need extended health insurance that is only obtained with through employment, or they should purchase privately. So for low-income old immigrants, it's quite actually difficult to use this service because of these problems. So based on of this information that I mentioned, my research question is about what are the characteristics associated with experienced health inequity in accessing primary healthcare among the older people in Canada, and how we can address those barriers. So I'm going to answer to these questions by using a four-phase design and multiple methods. First, I'm going to identify what type of people actually experience health inequity through the secondary analysis on a CLSA database, which stands for Canadian Longitudinal Study on Aging. And then I will going to use the result from the phase one in order to have an interview with this type of people, in order to hear their experiences about health inequity or the challenges in accessing their services. And then I'm going to have a focus group discussion with the key stakeholders and to know about the primary reason behind these disparities in health and develop some strategies. And finally, I'm going to, through the Delphi method discussion, through the Delphi method with the key stakeholders, I am going to check the feasibility, cost effectiveness, and applicability of these recommendations. So the data finally will be integrated into policy brief for public health decision maker in Canada. Especially in Nova Scotia. I'm going to consider the old adults across the Canada for the quantitative piece of my research, and just focusing on Nova Scotia for qualitative piece. Well, the Anderson's behavioral model of health services utilization is my research framework. And as you may know, it's one of the frequently used framework in healthcare system. And it's helped us to assess the health inequality in accessing services, understanding why people use services, and also help us in order to develop some strategies to address, health inequity in accessing services. And we can assess actually healthcare utilization just based on three main factors. One of them is the predisposing factors, which refers to basic characteristics of the individual, like sex, age, gender, time living in Canada, education, and enabling factors, which refers to the conditions that can be changed with individuals or social efforts, like, for example, the type of insurance that they have, the annual household receiving pension, and the need factor refers to the actually living with the pain and a history of the common comorbid conditions. The anticipated benefit of this study, definitely this study will help us to to know about the health of the older people and how healthcare system can provide a better support for them and satisfy their basic needs. And also it's contribute to our knowledge about the health inequity in accessing services and how we can improve access for all older people in Canada, and also strengthen a health system. And here are some of the references that I used for my presentation. And thank you so much for listening. Do you have any questions?
What a great presentation. Yes, we'll open it up for people to ask you questions. We have a fair bit of time. So is there any questions for Arezoo?
Yeah, I have a question. Great presentation, Ari, and I think you're gonna do a really big and interesting study. So good luck. Just want to ask about what type of older adult are you targeting? Because sometimes older adults, they have a lot of chronic diseases like dementia and comorbidity. So do you have like specific category of older adult, or what? And like, you are targeting older adult in nursing home or older adult hospital, or what type of older adult?
I said I'm going to find the type of the older people who experience health inequity in a community. I'm just focusing on the people in the community.
Good luck.
Is there any other questions?
I'll ask a question if nobody else will.
Sure.
That was great, Arezoo. Thank you so much. You had a slide up about intersecting factors that impact experiences of older immigrants. You might need to clarify for me, but what I was thinking in the next slide, you were talking about the how the healthcare system is funded here in Canada, and I was just wondering if, you know, did you include like characteristics or being an older adult as one of the intersecting factors? I'm just thinking about things like having to pay for medications and like hearing aids and walkers out of pocket is a big issue. And then older adults have more often mobility concerns and have higher rates of chronic diseases. So we'll actually have to use those resources more often. So yeah, just wondering, do you include the older adult piece in those intersecting factors?
Yes, I think, yes, maybe I am going to include them.
Okay. Good idea.
Thank you.
Great. And oh, Patrick.
Hi, I found that quite fascinating. I'm working for one of the hubs at AgeWell, and so our work is quite policy focused. So essentially, I'm working in knowledge translation and the policy sort of piece that's related. So I was very happy to see that in your trajectory, you're anticipating turning this into, or at least producing a policy brief. But, and I'm probably getting ahead of myself and maybe ahead of the research a little bit here, but I'm very curious whether you've seen so far in your preliminary work, what sort of policy levers you anticipate your research being applicable to. So like what methods would be able to be applied at, say, the provincial policy level to incorporate the findings and turn them into action, essentially?
You mean that what type of policy I'm going to use for? I didn't understand your questions.
More a matter of, like, if you could speculate, what part of the policy environment do you see your findings being most suitable for, or if I'm the knowledge translation person working between research and the final policy adopters, what concrete actions do you see policymakers being able to apply that are informed by the research you're producing?
Honestly, I haven't think about this part of my research yet. Well, and I'm just completely I haven't think about this part of my research yet, and I don't know. Honestly,
Maybe,
Okay.
Arezoo, I'll start. I can give you a couple initial thoughts and you can see if you can add anything. So on a provincial level, like we have the Department of Seniors and Long-Term Care and a lot of home care policies that rely on like one point person, so a continuing care coordinator who wouldn't necessarily have resources to support people that don't speak English or French, don't speak the dominant languages. A lot related to primary health care, primary care.
Yeah.
Arezoo talked very eloquently about the difference, but primary care, how people access primary care, and then access specialist care from that initial point of entry into the system. And then things like transportation, that's always an issue related to seniors, how people get around and actually needing more than, you know, point A to point B. They need a companion. And certainly in the case of people for, you know, new to Canada, they might need someone who can support them with cultural and language aspects, as well as the mobility and executive functioning that goes with that.
Yeah,
I could
those
probably
all
list, yeah.
just
I'd
at
be
a yeah.
really open and curious about what any other levers you could identify at this point.
Those line up roughly with what I would be probably looking at. And ultimately, a lot of that comes down to budgetary, twisting the right arms in terms of budgetary decision making and trying to get funding moving into areas where those kind of programs are most likely to be developed. The other thing too, with what the research hub I'm with looks at, is also things like leveraging technology where it's appropriate. So hypothetically, things like apps that can be used for language access in situations where health providers don't have resources on site to provide somebody who's language competent. They may be able to use some technology to access that remotely or bring things in that way. But that also can lead to additional issues if your client or patient who's working in the system isn't comfortable with that kind of technology. So with older adults in particular, you can sometimes wind up compounding an issue by saying, oh, we'll fix it with technology. It's like, maybe you won't. It's like, or at least not in the immediate term. So anyway, thanks very much for that information. That was helpful.
Thank you.
Great. So we probably have about 2 minutes left for comments. And I saw, Lisa, your hand was up, and now Lillian. I don't know if it's okay if I go to Lillian for just a very quick finishing up, and then we'll move to Lisa for her presentation. Lillian?
Hi, I'm nice to meet you. I think one area that you can focus is to help move more interpretation services for older people, because I'm an interpreter, and yeah, I was a doctor in Mexico. So here I just took that job as something like a not a full-time job, but now I see people move here, and usually they have the support of the family. But when you start giving these services, they become very reliable with you. Like they look for your help. Not it's only the language, it's the culture, it's how they feel, and also their family start looking for your services. But because I just work by an agency, and the agency need to assign that people, and the service need to look for the agency. It's a complicated process, and people at the end ended ask me as a volunteer, and I many times do it, but it's maybe it's if people know that this service is provided and is paying, and even people can work as a full-time job, for sure, I think that helps more in the integration with how the health system work and everything. And it's not necessary to learn the language, but to have the support to move these people to use the services.
Thank you so much for your information and feedback. Thank you.
Mm-hmm.
It was really helpful.
Well, I'm just going to bring this session to a close for you, Arezoo. Just thank you so much for your fantastic presentation. Good luck with your research. I really look forward to hearing your results, and also for everyone for their really thoughtful questions. So we're going to come to the second half of our session today, and it's with great pleasure that I introduce you to Lisa Goldberg, who is Associate Professor at the School of Nursing and is the Associate Director for Undergraduate Student Affairs and is a Caritas coach and really going to share her infinite wisdom with us today around fostering student success through the lens of caring science. So without further ado, Lisa, take us away.
Thanks, Marcia. Can everyone see this? And can you hear me?
Yes, beautiful.
Oh, good. Gosh, I've come so far with technology. It's mind-blowing. Okay, so thanks, everybody. I'm going to talk a little bit today a lot about caring science and you know how it's really helped in thinking about how I really foster success with students. And I've certainly written about it from many different perspectives, but I haven't yet written about it or done anything really from the perspective of my administrative role as an associate director. And so this was a wonderful way to kind of start thinking about that. And that's really what today is. But in order to do that, I really need to present about it first before I get writing about it. And so that's really what today is about. And I pulled some students, some of them I know. Noah's still here as one of the co-presidents of DUNS, and Annika has flown the coop and is applying to graduate school. So those are exciting things. So, you know, sometimes when people hear caring science, and I'm going to talk about love and miracles and all those things, they often think that it's so soft and it doesn't, you know, it is about compassion. And that's a huge piece of how I navigate my world, especially in my engagements with students. But I love Bell Hooks and what she had to say. And unfortunately, she passed away, I think it was a few years ago. But this is from her book, All About Love. But she also talked about it in a wonderful conversation with Thich Nhat Hanh, who is really a world-renowned Buddhist monk. And this passage was also in a really well-known Buddhist journal, Lion's Roar, I think is the name. And she says to me, all the work I do is built on a foundation of loving kindness. Love illuminates matters. And when I write provocative social and cultural criticism that causes readers to stretch their minds, to think beyond set paradigms, I think of that work as love in action. While it may challenge, disturb, and at times even frighten or enrage readers, love is always the place where I begin and end. And that really resonates with me when I think about where I do my work from a place of caring science. And Bell Hooks was an African-American scholar. She was a brilliant activist, educator, and it was a real loss, but her work lives on beautifully in so many ways. And this is certainly something I live by, these words, I think, and they inspire me on a regular basis. Caring science, there isn't just one, which I think is really important, but the one that resonates for me, the one I studied from, the one I've published from and worked with is that from Jean Watson. And I always say, if you ever get an opportunity to meet her, you really must. She is magical. And she is someone that you know, when you're in her presence, you just want to tell her you love her because she really is that sort of special person. And this work is grounded in the 10 Caritas processes. I'm going to talk about those because those are really the tools I use in the work I do. And what's amazing about her theory is it's in magnet, huge hospitals in the US, many of them actually. And what's very exciting is the recruitment and retention of healthcare providers, especially nurses, is off the charts. I mean, people do not leave those hospitals when caring science is woven through those institutions. So it's a very exciting way to be in the world. And it begins with the place of the self. And so if you don't know how to really reflexively and deeply care for yourself from a compassionate way, and it does mean really and deeply understanding your own position in the world. And that was something I was going to ask Arezoo about, sort of where she's coming from in her research. That was my question. So I got it in. But where, how do you come from the place you come from is a really critical piece in everything you do. So as a nursing administrator, educator, as a tutorial lead, as a clinical educator, it's so important to understand and really examine your own place, because that's the only way you can really understand how to work with students and really be compassionate and understand how to have them excel and succeed in ways that are so important. And it's a relational kind of place, not only with yourself and others, but also in the systems we work in. So it is about that one-to-one, but it's so much bigger than that, because we are in many ways in damaged systems. And so how do you do this work in systems that are deeply damaged? And a big piece of this is that EDIA framework, that equity, diversity, inclusion, and accessibility comes through that sociocultural, historical, political, and spiritual place where we work with all these different people. And for me, and many of us who are in the School of Nursing, it's working with students. And how do we do that and think about all these pieces so they succeed and excel with excellence? So Caring Science was developed in 1975, and it was really about bringing that spiritual caring and dignity to nursing. And it was initially defined as the curative factors, and it was about opposing that curing medicine with the caring of nursing. And that has really changed. I mean, if I think about my physician, who I see later today, she is so compassionate. She is a brilliant person, and I love going to see her. But that wasn't always the case. And it was a response to the objectification and compartmentalization of medicine. And there is still some of that, but nursing can do that sometimes too. So it's really thinking about how we value our humanity in the work we do and honoring that experiential inner life of the person we serve, collaborate with, and work with. And that's the same as when we work with students. And that's the initial basis for the theory. There's a gorgeous picture of Dr. Watson of Jean, and that's a pretty current picture of what she looks like. So it's really about this moving to a living, breathing theory for the nurse in the nurse's everyday personal and professional practices. So I think about this work not only in my professional life, but also in my personal life. Does it mean I do it right every day? Absolutely not. Like everybody else, I'm human. I have days when I come to the end of the day and I think, oh my goodness, I did not do that well for that student. And so how do I do it better the next day? And I talk a little bit about apologies as I move forward. This whole idea is, how do we hold space for other people? And Dr. Watson, Jean says, an evolved and continually evolving emotional heart. We need an emotional heart. We need that emotional intelligence and a consciousness and intentionality in all the work that we do. And it's a lifelong journey. You know, we talk about this with students. You know, it's lifelong learning. Well, it's not just for students. It's for all of us to have that growth and awareness in the engagements we have with students. And such an awakening of one's being and that ability to cultivate those skills and awareness of how we hold and convey and practice communicating thoughts of caring, loving kindness, and equanimity, which is about that balance, and so on, as part of our professional being. It doesn't mean you are not, that you don't have barrier, that you don't have kinds of barriers with students. It doesn't mean that, everything a student asks for that you do, but it means that in those engagements to help students thrive in an environment these days that is very challenging. And we've had such challenging environments over the last number of years with COVID, with strikes, and with all the things that students go through in their lives, just like all of us. It is about trying to figure out how to shift the way we do our engagements, and compassion has to be at the beginning of all of those engagements. And it is about that loving kindness. And as the Dalai Lama says, it's the strongest antidote to anger. And you know that if someone's angry, if you also get angry, you can see how that escalates. And that is not how we get to that wonderful place of strategies to move forward. It is about that loving kindness and that compassion. And one of my favorite Caritas processes, and I'm going to go through those and talk about the ways that we can work with strategies for supporting students. But my favorite is, it's not about sort of creating this external healing environment. It's about us becoming the environments that heal, because then wherever you go, whatever you do, you take that healing with you. So you could be in any space. Great example was at one time there was a student in crisis. I went to the residence, and you know, that room was not a healing place. But if you bring that healing with you, it really doesn't matter where you go. You become that healing environment. So caring science originates with the word caritas, and that comes from charity, compassion, and mercy. And it's organizations denoting charity in diverse ways. The wonderful thing about caring science, it can be applied to any area, any form of knowledge, any kind of research or clinical area, because it has such a wonderful diversity of knowledges. It's about a more mindful connection between love and gratitude. And again, love is a word that some people really have a challenge with, but it's kind of rethinking what that means. If you go back to bell hooks, you can see that it's not about romantic love. It's not always this soft, kind of gushy thing. It has a politicized stance to it as well, but it is that work in action. And it's about forgiveness, and it's about using a kind of literacy that Dr. Watson, that Jean talks about. To do this work, you need a certain kind of literacy to engage this work. And one of my favorite things is, how do we read the field when we're doing this work? So when you're working with students, are you paying attention not simply to individual students, but collectively what's happening with students, so we can intervene and do strategies before things become too problematic? And I think, you know, one of the things we're starting to work on, and certainly Margot and her team has been really instrumental in looking at how we begin to think about a trauma-informed school, which I think is such a remarkable thing for us to be considering. And that would get at things before all the difficulties happen. And I think that will have us looking at our policies, at our regulations, at our admissions, at absolutely every aspect of the school. And I think that is a really critical direction in which we're moving. I think, you know, supporting students through this work is really understanding their point of reference. And it may be very different from our own, especially when we're working with equity deserving groups, with priority groups of students. Their frame of reference, their experiences collectively may be very, very different from our own. And that requires us to also think about the distinction between equity and equality. That is critical to this work. And sometimes folks don't fully understand that. And those are things that I think are part of understanding caring science. And it's listening to both positive and negative feelings. And sometimes folks aren't good at hearing the negative. It doesn't mean that we hear only negative, but you have to hear some of the negative so you can get the information you need to use the strategies to move forward. So here are the 10 Caritas processes. And what I love about them is, if you've read any of Jean's books, if you've spent time with her, she is a remarkable theoretician. But what's remarkable in this work is there are these practical tools that every person could use in both their personal and professional life. And that's what I love about the theory. It has that practical piece to them that every person could use. And these are the tools that really guide the work that I do, and I think could guide any of us in our work with students for success. So here they are, but what I'm going to do is talk about them in a little more detail, and maybe some examples of some of the work that I do. I love this one: starve the ego and feed the soul. I think that's what we all need to do. So the first Caritas process is really about working from that compassionate and highly reflexive self before you can practice care and loving kindness with others in unforgiving systems. And, before I did the work in caring science, my work with students was very different because I don't think I really understood sort of that compassion for myself. And so I really didn't understand how to do that with students. And once I did that program, it was transformative and everything changed for me in terms of my work from students. And somehow, sometimes I think there is this view that the standard of excellence somehow reduces if you approach your work with students from a place of loving kindness and excellence. I can tell you that it absolutely doesn't. In fact, excellence becomes elevated when compassion is your guiding framework. And that has been shown to me over and over again as an educator, and indeed in the role I'm in. That authentic respect and honoring the experiences of others, particularly students, when they are most unlike your own. It's very easy to work with students or others who are mirror images of yourself. Where it is most important is when folks are not mirror images of yourself. And that's, I think, a key piece of caring science, is beginning to understand that many of the students you work with may not be and may not have the experiences you've had. So you have to begin to understand how to do that work with others who have very different from yourself. Moving beyond the ego is the big one. And don't allow your ego to get in the way of recognizing that you may very well be wrong. And an apology, particularly with students, goes a long way. And students have shared that with me over and over again. Because guess what? I have apologized many a times for making errors, because I make lots of mistakes, because we're only human. And that gives you a space and place to open when they know that you are willing to apologize for errors. Learning to cultivate those trusting and caring relationships individually and collectively. And it's amazing when you do that with a few students, it goes far and wide. And then you get that collective trust with students. And again, students don't thrive in spaces where they don't feel safe. And I think the biggest piece for all of us is excellence, and students excel when that trusting and relational space is created. Again, I've talked about that, creating that space for the positive and negative experiences and really opening that up. And that's, I think, where your ego has to turn off, because I've had an experience where it was a graduate student, a PhD student, actually, after a class came in and said, "You know what, Lisa, you made me feel very negative. I made the student feel very negative. And so I had to turn my ego off and really hear that and say, I feel terrible that happened." And we were able to work through that and move forward and have a wonderful relationship. But if I had my ego active and wasn't able to hear that, it would have been a very different situation. Diversity of knowledges. And I think that's a key one as we move forward, looking at, are scholarships going to be GPA dependent? That needs to change. And when we look at what we value as knowledges, when we think about indigenizing the university, when we think about what counts as knowledge, what we've had as traditional knowledge in the university, again, that's not the only knowledge that's valuable. And I think caring science does a beautiful job of talking about the multiplicity and diversity of knowledges. And that, again, shows students that it's not only one kind of knowledge that we value and think of when we're doing scholarships or when we're doing awards that value students and their diversity in the program. Developing a coaching model of teaching, and again, or of the work that I'm doing. Those sorts of things I think are really important. I've talked about become the environment that heals, because you can take your healing anywhere you go. I thought this was lovely. A healer is not someone who takes away your pain and disease. A true healer awakens the ability, your own ability to heal yourself. I think this idea that nursing is a sacred act and it's a privilege to embody another's world, never take this for granted. I think, what if we think about that as educators, as administrators, that the work we do with students is somehow sacred? Wouldn't that change the way we do the work we do? And finally, this one, which some people just lose their mind when I say this: be open to magic and miracles despite their denial all around us. I think there's something truly wonderful in that. I didn't always, but I sure do now. This is Jean and her wonderful daughter, Julie, and Julie does a lot of work with Jean now, and collectively together, oh my goodness, you would believe in magic if you spent some time with both of them. And she says this work is an invitation, an evocation, a call to enter into this space where there are new possibilities for shaping our lives, our work, and our world as we move forward into this new world. May we tread consciously and intentionally with love and light in our hearts and actions. And I'm going to leave you with that and a picture of my aging geriatric kitty, Petunia, who drives me bonkers these days. Questions? I'm going to take that screen away. Let's see. Oh, I hear a dog.
But oh, that's mine. So sorry, somebody at my door. Oh, what an amazing talk. So inspiring. Lisa, thank you so much for sharing. Is there any questions with people who have joined us today, or comments?
Just trying to stop share, and I can't. That one I'm missing now. Probably because my Teams has gone away. That's why. Yeah. I want to see people, so.
Should have a little X.
Yeah, hold on just a sec. I know what's wrong. Let that go. Yeah, you know what? My screen is gone. That's why. I might have to keep that on here.
Lisa, if you just see your little icon on the bottom and click your Teams, maybe it'll come up.
Well, I have my Teams here. I knew it was going to happen, but my other piece has gone away. Oh, wait now. I got another idea.
Okay, but let's
go.
I was going to say, let's just so that we don't
there it is.
Lose the opportunity for people to make comments since we only have a few minutes left. Yeah, anyone who'd like to comment? Lillian, is that your hand from the last time, or do you have another comment? Okay. Anyone? Marco.
Thank you so much, Lisa. I see you embody this work in your work with supporting the school and the students and working with faculty, to help us understand this way. And I really think you have such you definitely walk the talk, which is amazing. We're so fortunate to have you in that role. And, and thinking about the work that we're doing around trauma-informed, I know language is powerful, and somebody one day when I was presenting results, they said, "Why aren't you using the word racism?
Right.
Why aren't you naming it? You're softening the language."
Yeah.
And so that's why we went to the word trauma-informed. But I'd be interested in your comments, because as you describe caring science, it is such a beautiful philosophical but also action-based approach.
Yeah.
So I just wondered what you think about, the language that we use, and how you think people may interpret different approaches, such as if we're saying we're going to be a trauma-informed school versus we're a school that applies caring science. Are the two mutually exclusive, or do we embrace both types of language?
Well, you know, here's the thing. I've used caring science with homophobia and heteronormativity. I would use it with anti-Black racism and colonialism and sexism and all the isms. So I am never adverse to using the language of racism and homophobia, all the isms. So I think those things absolutely have a critical place in everything we do. It doesn't mean I don't. I mean, Bell Hooks is a great example. She would never have shied away from any of that language, but she also didn't shy away from love, right? So I think there's a place for all of those things that, I speak about homophobia and heteronormativity and all of those things. But it doesn't mean I won't do caring science. But I remember when the paper I did with myself, Neil, and Jean was on caring science and 2S LGBTQ+, and Jean's response was, "It's pioneering." Because it got rejected the first place because they didn't know what to do with it. It just was like, we don't know what, and a few of the people that we cited, they were, Laverne Cox. How can you not know Laverne Cox? And there were a few queer artists, musicians, but, whoever reviewed it, they just weren't paying attention to pop culture. But, they were very uncomfortable with that paper, but Jean wasn't. Jean thought it was phenomenal. And the next place we sent it, which she said, try here because the editor is much more progressive. He loved it. And so just see what I mean? I think there is a really critical place for all of that language in what we're doing. And, being on the EDI committee, certainly folks on the committee will say, absolutely, we need to have that language of racism. And if we do, we have to understand what that means in terms of what our obligation is to address it in the work we do.
Because people respond differently to language and terminology. Yeah, that's really helpful. Thanks.
Yeah, thanks, Margot. Yeah.
Wow. So if there's not any other burning questions, just to thank you again, Lisa. I think you inspire us every day and really, really make us have to pause and think about what we do, our language, how we treat people. I love your quotes. I love your leadership in this. And thanks for sharing with all of us today. And thanks for everybody for joining.
Thanks, everyone. And thanks, Lillian and Selma. And Selma, I've got to get it in. Selma did an amazing publication with Jean is on it, on looking at Islam and caring science. It's a gorgeous piece of work. So if anyone wants to read something absolutely magnificent, get in touch with Selma, brilliant Selma. She's got a stunning piece of work.
That's fantastic.
Yeah.
Fantastic. You should share that with us all, Selma. Congratulations.
Thank you very much. I think Lisa is one of the teachers that I would never forget, because really, really her class, the philosophy, it was special. It was my first time seeing a professor coming with her tea tray and the class was really full of magic. So she really inspired me, and for sure I will follow a lot of Lisa's way in teaching when I go back to my country. So I think, Lisa, you are always special, and as what Dr. Marshall said, you inspired all of us. So we appreciate the work you are doing. Yeah,
thank you so much. Yeah.
And so, yes, fantastic. And Selma and others, if you could send us the citation, maybe we could share that on our website, and certainly also list it both along with this recording, but also just share it, and we can send it out through Twitter and social media around the center. And thanks, Margot, for all those great ideas.
Marcia, one more. Sydney did a gorgeous one too that Jean is third author on, looking at caring science and technology in pediatrics. So that's another one. Yeah.
So, again, it would be a fabulous way. Send them to us,
Okay.
and we'll do a little series of, in follow up to our, our talk today around caring science. And this is also some excellent work that is coming from the school. And it's great for us. We're very happy to do that at the center to help promote. And then also it promotes people to continue to join the webinar. So thank you everyone for your time. I see it's right at 1 o'clock. So have a wonderful day.
I'll send you a bunch of the caring science publications.
Perfect. Send to Julie. Julie
Okay.
Berry.
I'll send them to Julie. Thanks,
Perfect.
everyone. Bye.
Thanks.